Okay, great. So welcome everyone again to the Orlando GI Journal Club for March. Welcome everyone. Our first study is a study published in Gut looking at the non-compliance with colonoscopy after a positive fecal immunochemical test. And they found that they double the risk of dying from colon cancer. So fecal immunochemical test, or FIT, is widely used for colorectal cancer screening. It's a two-step test, and a follow-up colonoscopy is recommended for a positive test. However, compliance with a follow-up colonoscopy after a positive FIT is only 50 to 80%. And therefore, this study aimed to evaluate the differences in colorectal cancer specific incidence and mortality in patients with a positive FIT test who did and did not comply with a follow-up colonoscopy. This was a retrospective study from Italy, where in this region they have a FIT screening program in place since 2002, so almost 20 years. The people who qualify are adults aged 50 to 69 years of age, and a FIT test is performed every 2 years. Every patient with a positive FIT test are contacted by phone, and then a colonoscopy is organized. So they included cohorts of patients who underwent the FIT screening program between January 2004 and September 2017. So the cohort that underwent FIT screening between this time period were then divided into two groups, either compliers, which meant that they underwent a colonoscopy within 12 months of a positive FIT, and non-compliers who did not. Now, the diagnosis of colorectal cancer was obtained from the tumor registry records and pathology records, and mortality data were obtained from the mortality registry. The primary outcome of this study was to compare the incidence of colorectal cancer and mortality from colorectal cancer between compliance and non-compliance. So this is the study population. As you can see, they identified nearly 90,000 patients who underwent colonoscopy after a positive FIT test, and about 23,000 patients who did not undergo colonoscopy after a positive FIT test. And as you can see, the total death rate in the complier group was around 4%, and death rate in the non-compliers was 8.5%. for total deaths. For colorectal cancer associated deaths, it was 0.38% for compliers and 0.72% for non-compliers. They also looked at the adjusted hazard ratio of colorectal cancer incidence and mortality in patients with the positive FIT test. And basically what they are looking at is your risk of death. That's what hazard ratio is basically. So when you go look at this, table, if you go to the bottom row, this variable is compliance with colonoscopy. And as you can see, if you complied with a follow-up colonoscopy after a positive FIT, if you did not comply with the follow-up colonoscopy, as in you are in this no row after a positive FIT, the hazard ratio, so colorectal cancer incidence, is actually risk is 2 compared to those patients who did undergo colonoscopy. So the risk of colorectal cancer incidence is actually 2.03, and it's basically twice that of people who did undergo colonoscopy after a positive FIT. And so that is referring to the risk of death from colorectal cancer in patients who did and did not undergo colonoscopy. Now, this is the cumulative instance of colorectal cancer incidence after a positive FIT in a graphical format. And as you can see, when they looked at the 10-year cumulative incidence, the incidence in compliance was 44.7 per 1,000, and in non-compliance was 54.3 per 1,000. If you look at the cumulative colorectal cancer specific mortality in patients who tested positive in their FIT test, for a 10-year cumulative mortality, the incidence was 6.8 per 1,000 in compliance and much greater at 16 per 1,000 in non-compliance. And as we went through in the prior table, the risk of death from colorectal cancer was significantly greater in non-compliance versus compliance, with hazard ratio of 2.03. The main limitation of the study is that it's a retrospective study, and there are no control for other risk factors for colorectal cancer in the non-compliance. And the main take-home point is that the failure to complete a colonoscopy after a positive FIT test resulted in a markedly increased risk of dying from colorectal cancer. The excess risk of colorectal cancer deaths among individuals not completing colonoscopy after a positive FIT test should prompt screening programs to adopt effective interventions to increase compliance in this high-risk population. Our second study was published in Gastroenterology, and it's looking at the timeline for developing pancreatic cancer and implications for successful early detection in high-risk individuals. So this study is important because current screening, although in limited use for pancreatic cancer, relies on using endoscopic ultrasound or MRI or both in high-risk individuals who are defined as having strong family history or being positive for pancreatic cancer susceptibility gene mutation. There is evidence that pancreatic cancer detected by surveillance in high-risk individuals are downstaged, and some patients achieve long-term survival. However, it is unclear what proportion of high-risk patients who develop pancreatic cancer develop detectable imaging abnormalities associated with precursor lesions, and how fast these precursor lesions progress to invasive disease. So the aim of this study was to obtain a timeline of imaging abnormalities in high-risk individuals undergoing pancreatic cancer screening, which then leading to high-grade dysplasia and pancreatic cancer. So this study was from the International Consortium for Cancer of the Pancreas Screening, also known as CAPS. And these are groups of centers who have a pancreatic cancer surveillance research program. And they have high-risk individuals who undergo periodic imaging per established surveillance protocols using endoscopic ultrasound, MRI, or both. Now, this is involving 16 centers and 7 countries. And as you can see, the surveillance program consists of screening high-risk individuals who have proven germline mutation in at least one known pancreatic cancer susceptibility gene and a strong family history of pancreatic cancer who are untested or negative for genetic mutation. The median follow-up in this study was 29 months, and the primary outcome was to look at the development of neoplastic progression during follow-up. Neoplastic progression in the study was defined as developing high-grade precursor lesion, either pancreatic cancer in situ, IPMN with high-grade dysplasia, or pancreatic cancer. They identified 2,552 patients who underwent surveillance for pancreatic cancer, and they identified 122 patients who underwent, who were identified to have high-risk lesions. 14 of these 122 patients had unresectable pancreatic cancer, and the remainder actually underwent surgery. Now, out of these 122 patients, neoplastic progressors were identified in 57 patients were identified as neoplastic progressors. So as we went over before, those were patients with pancreatic carcinoma in situ, IPM with high-grade dysplasia, or pancreatic carcinoma. Now, looking at the timeline of development of neoplastic lesions, they found that 28 patients had neoplastic progression. Out of these 28 patients, 13 patients had new lesions which were discovered at a median of 11 months after a previous examination. And 10 of these 13 patients had non-resectable cancer. 15 of the 28 patients with neoplastic progression actually were identified in a previously detected lesion, and 11 of these 15 patients with neoplastic progression had non-resectable cancer. They then also looked at factors associated with surveillance success, which they identified as finding a neoplastic lesion, which when removed was identified as being cured, so surgical margins that were clear. So they basically found, not surprisingly, that larger the lesion, the lower the risk of surveillance success. And cystic lesions were associated with greater chance of achieving surveillance success, rather than, say, solid lesions. The main limitations of this study is that it's retrospective. There are a relatively small number of cases who were identified as having neoplastic progression, and they were not able to obtain genetic confirmation that the cancer arose from a previously known precursor lesion and did not arise de novo from a separate mutation or area or lesion in the pancreas. So the main take-home point is that in nearly half of high-risk individuals developing high-grade dysplasia or pancreatic cancer, no prior lesions were detected by imaging and presented at an advanced stage with progression occurring at median of 11 months, i.e. it was prior to their originally scheduled next annual examination in some cases. And therefore, we need a more sensitive diagnostic tool or a different management strategy in patients who are high-risk individuals with rapidly growing cysts and lesions. Our third study is a study looking at endoscopy-related bleeding and thromboembolic events in patients on direct oral anticoagulation or vitamin K antagonists. So prospective studies evaluating the safety of direct oral anticoagulants and vitamin K antagonists, which in the United States, the most common used vitamin K antagonist is warfarin, although in this study, which was set in Spain, it was not warfarin, but a different agent, which was supposed to be comparable in patients undergoing endoscopic procedures, are scarce. Also, the timing of resumption of anticoagulation is controversial, with recommendations based on usually expert opinion and retrospective data. Therefore, the aim of this study was to compare the incidence of endoscopy-related gastrointestinal bleeding and thromboembolic events in patients on direct oral anticoagulation or vitamin K antagonists. So it's a prospective study involving 12 centers in Spain who underwent an elective endoscopic procedure from January 2018 to 2019 December. And these patients were on either vitamin K antagonists or any type of direct oral anticoagulant. Now, the primary outcome was to look at the incidence of thromboembolic events at 90 days and endoscopy-related clinically significant GI bleeding at 30 days post-procedure. Thromboembolic events were identified as PEs, DVTs, acute coronary syndrome, stroke, TIA, peripheral artery thrombosis or embolism, and clinical significant GI bleeding was any GI bleeding requiring ER visit, hospitalization, or intervention, endoscopic or otherwise, such as IR or surgery. Now, they were able to identify a total of 1,602 patients who underwent elective endoscopic therapy with known treatment with vitamin K antagonist or direct oral anticoagulation. There were significantly more patients in the vitamin K antagonist group at 1,004 versus direct oral anticoagulant group of 598. Now, as you can see here, a relatively small proportion of patients, so that's 0.8%, were also on clopidogrel as well as anticoagulation. If you look at patients who are, according to their thrombosis risk, high-risk patients accounted for about 30% of the cohort versus 70% who are low risk of thrombosis. They then also looked at the dose of the last anticoagulant dose before endoscopy. And as you can see, the majority of the patients, about 3/4, had actually received anticoagulation within 48 hours of the endoscopic therapy. After endoscopy, in the majority of cases, over 90% had resumption of anticoagulation within 48 hours of the endoscopic therapy. Now, these are the procedure details. The group and centers involved in the study were not interventional or advanced endoscopic centers. And so the majority of the patients underwent diagnostic endoscopy or kind of minimally invasive interventional procedures. But they do have 0.2% who underwent upper ESD, 1.6% who underwent ERCP with sphincterotomy, about 1% of patients underwent EUS with fine needle aspiration, and they say that patients underwent high-risk procedures in the upper GI tract in 18% of the cases. When looking at lower GI tract interventions, ESD was performed in 0.4% of the cases, hot snare and cold snare polypectomy in about 35% of cases, and they say that the high-risk procedure group accounted for about 59.9% of the cohort of patients who underwent lower GI tract interventions. Now, this is looking at the outcome variables of incidence of bleeding, mortality, and thromboembolic events. And as you can see, there is no significant difference with between vitamin K antagonists and direct oral anticoagulants in terms of bleeding risk, thromboembolic event, or mortality. And if you want to just focus on the actual rate of bleeding and thromboembolic event, I would say that the risk of gastrointestinal bleeding is not insignificant, 6.4%, with lower thromboembolic event of 1.4%, and there was a 1.4% incidence of mortality at the end of the 90-day follow-up. The authors then also performed a subgroup analysis, and they looked at the risk of bleeding according to the timing of anticoagulant resumption. And if you just focus on this area here, in patients who are undergoing high-risk procedures, they didn't detect any significant difference in the risk of bleeding according to the timing of anticoagulant resumption. So the risk of bleeding when anticoagulation resumed within 24 hours was 5.8%, within 24 to 40 hours, 9%, and then after 40 hours is 10.2%. The main limitation in this study is that the majority of patients underwent diagnostic endoscopy with biopsies or had low-risk endoscopic procedures with low number of interventional invasive procedures such as ERCP with sphincterotomy, advanced resections, and EUS-guided final aspiration. And as mentioned before, in Spain, warfarin is not routinely used, and so they used a comparable vitamin K antagonist called acinocumaril in 99.1% of the patients here. So the main take-home point from this study is that in patients on direct oral anticoagulants or vitamin K antagonist undergoing elective endoscopy, Endoscopy-related bleeding and thromboembolic events showed similar risk between these two groups. Early anticoagulant resumption appears to be safe in most patients. However, more data are needed for advanced high-risk therapeutic procedures. This is our final study. It's a study looking at the effect of domperidone therapy on gastroparesis symptoms. And it's the results of a core study by NIDDK Gastroparesis Consortium. So I'm sure everyone's already aware, but the pharmacological agents in the treatment of gastroparesis is limited. And in the United States, there's only one FDA-approved prokinetic agent available, which is metoclopramide. However, the use of metoclopramide is limited due to its side effect profile. Now, domperidone is a dopamine agonist at the dopamine antagonist at the D2 receptor with prokinetic effects in the stomach and proximal duodenum by inhibiting the D2 receptors in the enteric nervous system. And it's available through the FDA investigational new drug application. However, the use of domperidone for gastroparesis remains controversial, especially because it can be a challenge to obtain, especially in the United States. So the aim of this study was to look at the outcomes of domperidone therapy for treatment of gastroparesis. So it was a prospective study of patients enrolled in 2 long-term observational NIDDK NIH Gastroparesis Clinical Research Consortium studies, patients which have enrolled diabetic or idiopathic gastroparesis who are not on domperidone prior to study enrollment. And the authors compared the symptoms in patients who had domperidone initiated during a 96-week follow-up and those who were not started on domperidone therapy. The follow-up period was 96 weeks. So as you can see, there were 181 patients in the domperidone group, 567 patients in the non-domperidone group. And as you can see, the symptoms prior to the symptoms at the baseline of the study was more severe in patients in whom domperidone was started. When looking at the effects of domperidone therapy, as you can see, the total gastroparesis cardinal symptom index was significantly lower in patients who had domperidone. Also, the nausea subscale was improved, the feeling of fullness was improved, and upper abdominal pain scores were also lower in patients who were on domperidone during the study period compared to those who were not. So the main limitation of this study is that there is no information on the dosage range of domperidone. And additional gastric emptying studies following initiation of domperidone are not available. So we are not clear about the effects of domperidone in the actual gastric emptying study results. So the main take-home point of this study is that domperidone resulted in a moderate but significant improvement in gastroparesis symptoms. So for recap, failure to complete a colonoscopy after a positive FIT test resulted in markedly increased risk of dying from colorectal cancer. Excess risk of colorectal cancer deaths among individuals not completing colonoscopy after a positive FIT test should therefore prompt screening programs to adopt effective interventions to increase compliance in this high-risk population. In our second study, it showed that in nearly half of high-risk individuals developing high-grade dysplasia or cancer, no prior lesions were detected by imaging and presented at an advanced stage, with progression occurring at a median of 11 months, which was prior to the next scheduled routine annual examination in some cases. More sensitive diagnostic tool or different management strategy are therefore needed for rapidly growing cysts and lesions. Number 3, in patients on direct oral anticoagulants or vitamin K antagonists undergoing elective endoscopic procedures, endoscopy-related bleeding and thromboembolic events showed similar risk between these groups. Early anticoagulant resumption do appear to be safe in most patients. However, more data are needed for advanced high-risk therapeutic procedures. Number 4, domperidone resulted in a moderate but significant improvement in gastroparesis symptoms. So this concludes our GI Journal Club for March. Our next monthly GI Journal Club is the first Wednesday of April, which is April 6th.